thank you very much, Agnes, and I'd like to also personally congratulate the committee on a fantastic day today. This is a testament to all your fantastic hard work. So my introduction's been done. The other thing I'd say is I was very fortunate to spend 2 years at a sickle cell centre in the US, so the Sickle Cell Centre at Duke University Medical Centre, which is one of 10 centres for excellence in the US. And so I think this is one of our other initiatives, is to make sure we're sending clinicians to some of the other places around the world to learn about treating sickle cell disease, and it's really important. So my job for the next 10 minutes is really just to set the scene for our panel discussion and just to make sure that we're all together in our awareness about what sickle cell disease is. So it's a single change in the genetic code for haemoglobin, and it wreaks havoc throughout the body, unfortunately. The problem is it turns our red blood cells, which carry our oxygen around the body, from these nice healthy red cells you see on the left, to sickle cells on the right. And as many of my smaller patients will know, I call these cells bent bananas. And what happens during a sickle cell crisis, it's a bit like shoving a bunch of bananas in a water pipe. And that stops the blood getting around the body and makes the oxygen levels drop and causes damage to the tissues throughout the body. So that's what happens when we have a sickle cell crisis. And it causes a number of problems throughout the body, both acute complications but also chronic complications that you'll see here. It's a really exciting time for sickle cell disease at the moment because we have a marked improvement in our knowledge of what causes problems in sickle cell. And so we now know that beyond the red blood cell problem, there are lots of other systems in the body that are involved in sickle cell disease. So we know a number of these other cells you'll see down the bottom, so white blood cells, platelets, and lots of other chemicals in the body also mediate the terrible tissue damage that we can see during a sickle cell crisis. This sort of information is really important and has completely changed the landscape because now we've got lots of other targets and other things to focus on in trying to help patients with sickle cell disease. So how big is this problem? It is a global health problem. The frequency of mutations in the haemoglobin gene throughout the whole population is between 1 to 5%. So that means many of us have problems with these genes. It results in problems such as sickle cell disease, as we've heard. We know that now there's patients with sickle cell disease throughout the world. We're a very mobile population and we all live in lots of different places, and so sickle cell previously was really located in just a small number of countries, and it's now seen throughout the world. But one of the problems we have with sickle cell disease is 90% of patients who are affected are in low and middle income countries, and that really can cause a problem in terms of having access or opportunity to do lots of research. So where are we now? So a recent study published in 2015, you'll see that Australia is actually finally on the map in terms of being sort of acknowledged for having a reasonably large sickle cell population. But as I've mentioned, most patients with sickle cell disease live in sub-Saharan Africa, the Indian subcontinent, and also in North America. So we've already heard a little bit about the Haemoglobinopathy Registry, which has been run out of Transfusion Outcomes Research Collaborative at Monash University with the Australian Red Cross Blood Service. And this really started back in the mid-2000s, where an Australian Paediatric Surveillance Unit started to capture data on new patients diagnosed with sickle cell disease, and that's really now been expanded to include both adult and paediatric patients. For the current registry, we have 381 patients on the registry, 13 sites involved, 8 of which are actively recruiting. And the number of patients on the registry is 128 who identify as having sickle cell disease. These numbers are increasing, however, and I think in reality this is really the tip of the iceberg in terms of how much sickle disease we're seeing in Australia. So we're very fortunate in Australia to have excellent medical care, as we've heard, and really my experience in the US, I came home so grateful for the opportunity to work in fantastic public health that we have in Australia. We have access to all of the therapies that we see that are used throughout the world to treat sickle cell disease. A number of them are listed here, and I'll just walk you through some of these treatments. As Agnes has alluded to, there's very good consensus and evidence-based guidelines now on how we treat sickle cell disease, so we can make good decisions in terms of what we can offer to our patients. Many of these are out of the US, but also some of the European countries. This is the most recent version in 2014 from a large group in the US, but now we have similar guidelines throughout Europe, but no local guidelines in Australia. And these are regularly updated, so a new version is due at the end of this year. Really, even in my career, hydroxyurea is a medication that has completely revolutionised the treatment of sickle cell disease. This is a medication that we know reduces the amount of those sickle cells that I showed you at the start, but also targets many of the other aspects of sickle cell disease that I mentioned, so the white blood cells, some of the chemicals that cause the inflammation and the tissue damage. We have lots of evidence now that hydroxyurea works really well for patients with sickle cell disease, and this evidence is both in adult patients but also paediatric, and you'll see from some of the names there, baby hugs. That's a study done in babies down to 8 months of age, and patients now born with sickle cell disease will have a very different experience because of medications such as hydroxyurea. Another big part of my job is to make sure I'm looking after my patients with screening and prevention strategies to really reduce the complications that we see from sickle cell disease. This is really important things like preventing life-threatening infections with vaccinations and antibiotics, but making sure I'm looking after things like kidney disease, lung disease, blood pressure and eyes, as well as some of the more dreaded complications such as stroke. So this is a really important part of clinicians knowing, as Agnes has mentioned, what are the things that they need to be looking out for and how do they know sort of how to monitor patients with sickle cell. As we've already heard, blood transfusion is an essential part of treatment for sickle cell disease for many patients, and it's certainly of great benefit to many of our population. The problem is that this comes with some risks, and these can be related to things like too much iron in the blood, causing iron overload, but also the risks of infection, and also some of the problems we see where there is genetic variation or difference between our blood donors and the population of patients who need to receive blood regularly. There's been incredible advances in transfusion medicine science as well in the last few years, and this is really of fantastic benefit again for patients with sickle cell and other hemoglobinopathies. Again, our evidence base for when we need to use transfusion in sickle cell disease has also significantly improved over this time period. So as we've heard a little bit about, red cell exchange is really a very specific transfusion treatment that we use for sickle cell disease, and really even our access to this treatment has vastly improved in Australia. It's a process where you'll see the patient is actually hooked up to a machine, which is called an apheresis machine. It has a big centrifuge in it, which spins the blood really fast and allows us to separate the different layers of the blood and to take the sickle cells out of the patient and put new blood cells into the patient. And so that's a therapy that's growing increasingly in sickle cell, but many other diseases as well. Again, our evidence base for using this treatment is now much stronger than it ever has been in terms of a number of studies that have really helped us to work out which patients will benefit the most from this treatment. So what's new in sickle cell disease care? As I mentioned, it's an exciting time for patients and clinicians. There's more than 200 active recruiting trials around the world at the moment, and 70 of these are in what we call phase 3. So in medical terms, this is the phase just before these treatments really reach the clinical coalface where we can offer them to patients. Quite a number of these trials are related to bone marrow transplant and gene therapy, but a number of them relate to medications that I can see will become available in the next couple of years. So many of our new drugs are going to target some of those things I mentioned at the start, the white blood cells, the chemicals, the inflammation, blood clots that we see in sickle cell disease and breakdown of red blood cells, all of really which can exacerbate the clinical condition for the patient. For the researchers in the audience, this is really a summary table of where all these drugs are up to, and you can see there's lots of different targets that we're seeing on the left, and these are all the drugs we're using, and these are the different phases that they're in. So you can see this is a very exciting slide for a clinician who can look ahead and say, well, what am I going to have in my toolbox to offer patients that I see with conditions such as sickle cell? Where do I think this is going? So I think in reality what we're going to need is a multi-targeted approach. So for patients who don't need transfusion or are not at the point of needing a bone marrow transplant, using a different cocktail of medications to try and control their disease will be really important. Thinking about transplants, we've already heard from Agnes about transplant. This is the only therapy we have currently that allows you to cure sickle cell disease. But one of the biggest problems is less than 20% of patients will have an appropriate brother or sister or sibling bone marrow donor. So therefore we're not able to offer this to all patients, unfortunately. It is a risky procedure, so it's always a situation where we're having to balance some significant acute risks versus significant long-term benefits. This is a current summary slide of where all the bone marrow transplant research is up to. So you'll see there's lots of activity in that space as well. And what you'll see at the top is that now we have many thousands of patients with sickle cell disease who've undergone bone marrow transplant. And that really allows us as clinicians to become very aware and to sort of improve protocols so that we get the best outcome for patients. But most of the bottom studies are actually looking at different ways to do transplant where we might be able to expand who we can offer the transplant to beyond the 20% who have a match. So gene therapy, many of you who keep up with the popular media will see gene therapy is also a very hot topic in sickle cell and thalassemia. And Australia's been at the forefront of this, with one of the thalassemia patients in Sydney being involved in the very original gene therapy trials in beta thalassemia. So we're up to about 20 patients with sickle cell disease having gene therapy in centres, particularly in France, and 3 centres in the US that are looking at this therapy. But I think this is just really the start of ongoing development that will really offer another alternative cure for sickle cell disease beyond bone marrow transplant. So just to finish, what are some of our local challenges in Australia? One of the issues we have is our patients come from all over the world. So unlike some of the populations overseas that all come from the same place, we have a sort of very ethnically diverse population. That affects how patients present, but also some of the complications that they may have. So it adds sort of challenges as clinicians in terms of what we need to be aware of. It also has implications for safe blood transfusion. As we know, as we've already heard this morning, without good statistics and data on the epidemiology of sickle cell disease, that also makes it very hard to plan. How many doctors will we need to look after sickle cell disease? We need to train nurses. How do we sort of factor that in terms of where we're heading? So that information will be really important. As we've also heard from Agnes, without newborn screening, many patients with sickle cell disease in Australia actually present in middle childhood. They're not found till much later. And that means they're often presenting with complications and not getting the treatment they need from very early on in life. Transition of care, where patients move from paediatric services to adults, is often a very challenging time for families, and we certainly have some models here in Australia, but internationally this is often a time of significant stress for patients with sickle cell disease, and it's something that we will have to work on as clinicians and as a community in terms of caring for patients and families with sickle cell. So where do I see the future in sickle cell disease? Improved transfusion practice, thinking about new medications that will help us to look after patients, and then things like bone marrow transplant and gene therapy are our future. So where to from here? Echoing many of the messages we've already heard, advocacy is really important. So this is a rare disease, but it has significant impact for patients in terms of quality of life. And so access to healthcare and pathway development is really important. So a number of the clinicians involved in sickle cell care are in the room, and I'd like to thank them for their ongoing support in terms of obtaining the skills we need to really make sure we look after patients well. But awareness in primary care, so teaching GPs, medical students, nursing students, emergency departments, paediatricians, physicians, teaching the whole medical community about sickle cell disease is really important. We need local champions, both in the community but also in our hospitals, to make sure that there's a good awareness that, of the therapies I've discussed and how to really look after patients with sickle cell. And promotion in terms of blood donation and community awareness is really important, so to make sure that we're doing everything we can to support patients and families. So the clinician-patient and advocacy group partnership is really important, I think, in all of these steps. And so I'm thrilled to be part of the association and to continue to work with you as we move into the future. Thank you.